Test 1 1.
You can put that one.
I'm D. T. Nguyen. I'm sitting in for Chairman Patty today. He has some business to attend, so I'm going to chair the meeting. Do we have anyone sign up? Nobody signed up for the to address the committee. The next item for the committee is the approval of the minutes from last month. May I have a second?
Second.
Any discussion? If none, all in favor, signify aye.
Aye.
Any opposed? Motion pass. Next item on the agenda is the approval for the facility planning. I'm going to ask David to come up and our COO, Jill Farrell, to come up for it. Good morning.
Good morning. We are going to share the updated placemats for this month, and David Watkins from Bratislava is here to do that for us.
Okay. We got the next slide up, or? Sorry. Still the new guy. All right, starting with Psychiatric Emergency Center. Well, I guess first of all, we're still on track to be the summer of 2025 for construction. We did turn over 45 parking spots earlier than expected. Good news is slab is 100% down, so all the concrete's poured, which means that'll hopefully shorten some of our weather delays that we've been getting hit with because of the rain. The good thing is steel is marching ahead of schedule. It's making up some of those weather delays as we move into the interior of the building. Framing's underway. MEP's going as planned. I mean, we're moving right along. We're on schedule. Things are good. Medical Home Southwest. Talk about that one real quick. Our go live date is still the end of the year. On schedule to make that as well. Exterior's underway, stone and bricks going on. Equipment procurement has begun, ordering some of the longer lead items on the equipment, getting that moving. And I guess the big thing is, interior framing's complete, but mechanical, electrical rough-in is going in all zones of the building right now. And things are moving on time, on schedule. You saved the best for last. Okay.
Let me make sure, because we have two representatives from that area. Do you guys have any questions on the medical home there? Go ahead, if you have comment on it.
No, it's moving, like it's moving real fast. And I guess my question is, the property owners on each side, I hope we can talk to the city or somebody to address, because the grass is about as tall as me, and I'd hate for us to complete that, and then it's terrible on both sides.
Okay, we actually have a visit out there. Jill and I enjoy going out this afternoon, so we'll take a look at that.
Yeah, it's, with the brick up there, you almost think you're ready. It looks really nice, really nice. Can I move in soon?
We have your room, or your tower, penthouse.
Go ahead, David.
All right. Moving on to temporary parking. This one's easy. It's open, it's running, it's operational. We've started closeout process with all the contractors and subcontractors. That'll take a little while to complete. But other than that, up and operational and running.
Efficient parking and everything.
Yeah, shuttles going, security's up, card booth's up, blue phones are working. Things are good.
Yeah, we made that big switch this week with the temporary lots, and so it's been an adjustment period for the week, but we will definitely get there from a parking perspective. It'll also help, David mentioned opening up next week this extra lot that we didn't anticipate over in front of TSP, and so we'll be working through that in the coming days as well as we open up a few more spots on the campus.
Have we had any patient experience with the parking and JPOC so far?
We're taking feedback from not only patients but also staff. Our parking committee is meeting every evening to go through those questions. We actually set up a parking email so people can send those things in from an employee perspective, but also getting feedback from patients as we go along and making adjustments as needed.
Thanks.
Also, I'll share with you, next month, we'll be bringing a new placemat as we're kind of rolling off the temporary parking placemat and bringing on the garage. With all the parking changes, obviously with the temporary lot that's been opened, we've captured all of JPOC as we start to work on the new garage and then ultimately also the medical outpatient building. So we'll start bringing that forward next month and we'll talk about the new garage. Last slide here, I'm going to touch on, we historically did have a dashboard that showed the overall cash flow. This is another version of that, and what we tried to do is really kind of simplify this so we can make it as large as possible. What I'll draw you to is the top slide is the overall cash flow for the entire project, which makes it really hard to see when you're looking at the graph. And so what we did with Cummings and David and Broadus is we actually created the slide below, which is really a more focused view from the beginning of the project to where we are now. And what I'll say is there's really two aspects that are viewed here. First, I want to draw you to the actual bars that you see, the blue and the yellow. The blue bar is the projected in a quarterly view. So as you can see for FY24 quarter one, our projected spend just for that quarter was $30.7 million, and we actually spent $32.4. So you see there's some catch up there in the quarter. But then I'm going to draw you to the actual bar lines. This is the cumulative project view, and so there's an orange and red line. And if you look at the same time period for for FY24 quarter one, the projection was $88.8 million for spend, and our actual cumulative is $81.9. So we're not quite where we thought we were going to be, and we know we've had some delays getting the projects going, but I think when we were asked the question, are we spending money, this definitely shows that yes, we are spending money with all these projects that are live. So hopefully this is a better view to look at in this committee.
Any question from our committee?
You know, it took me a while to understand it, but I finally got it. That I do like the actual cumulative. It shows a better picture. Yeah.
I know we discussed this, but maybe sometime in the future about the disruption, the cost of migration, disruption, temporary and implementation type thing down the road. But that'll be coming later on. That way,
As we onboard the projects.
Right.
Okay, to put in the operational costs.
because sometimes people forget that it's not just the building we turn it on, it's a whole operational efficiency and disruption and all that stuff that may interfere with some of the services. Any other comment or addition? Nope, not. Thank you so much for this, and that chart looks really good. Thank you.
Great, thank you.
Right, Mr. Rory McCarty, our interim CFO for the report.
We're turned on here. Good morning. A couple of things, just kind of general items before we dive into the financials. This month, we will go through the regular financial packet, but we also have a dashboard, a financial dashboard that will focus on some of the key metrics and measures that we look at. This is kind of an organizational-wide effort to bring to you metrics in a dashboard for a number of areas, one of those being finance, one of those being quality. And so we'll begin to look at that monthly. Additionally, the annual budget process has begun. We are looking at that budget process and accounting for a couple of at least big projects, the Medical Home Southwest and the PEC, which we talked about. They will both onboard and will feel the financial impact of that in fiscal year 25. And we also have a project around Las Vegas Trail, which we anticipate to be in 25 as well. Lastly, we're getting closer to some funding from the Texas Comptroller's Office around the opioid settlement. There are a number of things that the Comptroller is working through there before the release of those funds will occur. JPS will be receiving significant dollars from that opioid settlement. And then we will bring some resolutions in the month of May to designate an authorized official for JPS to not only account for the funds, but be accountable for any funds that are not spent that might need to be returned to the state if that should happen to occur. So we will get into the financials. Over the last several months, I've been thinking about how we go through multiple graphs. So this month, I'm on this statistics summary page. It's a nice colored graph, but I created a summary so we can go through things a little bit quicker. But before we get into that, let's kind of talk about just overall. Overall, the financials in March, volumes were slightly down. Almost, you might say flat, but slightly down. Net patient revenue was, again, favorable due to our commercial payer mix. Expenses were favorable to budget, and then our investment income was favorable as well. So all in all, our net income for the month is about $9.8 million. So I'd like to give you a quick summary before we get into all of the numbers. But here's the volume slide that I was mentioning, our statistics. So just to explain the scale, so anything that's green is more than 3% favorable to budget. Anything that's red is more than 3% unfavorable. And then anything yellow is kind of in that middle range. So you see where we're at in March, and you also see where we're at in the far right column year to date. So admissions were slightly down about 1%. Length of stay, we recorded the second lowest length of stay in the last 12 months at 5.46. We've only had one other month perform better than that. So length of stay continues to be moving in a very good direction for the organization. Emergency visits continue, as you can see, for the entire 12-month period. We continue to outpace emergency visit budget numbers. A lot of that is attributed to the efforts and work around left without being seen, and continue to see less of our patients that don't get seen timely. And so we really capture a lot of additional visits there. Urgent care, a little bit of a red number there in the month of March. We did have 5 Saturdays and Sundays in the month of March, which typically those days the volume is actually off compared to a normal day. About an urgent care weekend day is about a third to half of what a normal day is. So we also are seeing seasonal adjustments for COVID and flu starting to fall, and as well, those numbers do compare to the prior year. So not anything unusual there, but we do start to see those seasonality things kind of start to drop off in March.
Is there a possibility that we can add one more month so that we can see what March 2023 look like and March 2024?
Yeah, that's not a problem. We can do that for you.
Because I was trying to check to see if that's seasonal, or is it spring break, or we actually have providers that actually taking vacation with spring break. That
we could do that for you.
Capacity issue.
And then we did start an initiative in the urgent care in the month of March around kind of our out-of-network population. We've really been focused on kindly redirecting patients to their hospital of choice or their network of choice. And so we did see some left without being seen uptick in the month of March due to that as well. I would note primary care is just in the yellow, of course, but although they're slightly down for the year, they're actually up 4.3% over the prior year. So it's a very positive indicator that they're up 4.3% over the prior year. And looked into specialty care a little bit. They are benefiting from some additional providers in gastroenterology, wound care, endocrinology, and pain management. So that's really helping the specialty care numbers look better. We've talked about inpatient surgery quite a bit. There's not a lot of new information around inpatient surgery. Trauma did normalize in the month of March, so we've actually seen kind of a trauma number come back in line in the month of March, but we do have one vascular surgeon vacancy that's contributing a significant number of cases on the inpatient surgical side. We've talked extensively about behavioral health and the PEC, kind of that relationship, and how the PEC continues to shift that volume into the clinics. And then there's a new indicator at the bottom called adjusted patient days, and what we do is we count patient days, but we also add a factor for outpatient activity and equate that outpatient activity to an inpatient day. And so we'll start to look at that a little closer, because it's really a measure of our overall volume in terms of inpatient and outpatient. I'll stop there, take a breath, and is there any questions that I could answer on the statistics?
Help me with the adjusted patient days. What are we measuring again, and
Okay.
how will that compare to other institutions?
So if you just measure, let's say admissions, or you just measure surgeries, we don't always pick up the enormous outpatient activity that JPS have. We have, I think it's somewhere around 55% of our revenue is outpatient. So adjusted patient days is intended to factor in outpatient revenue as if it was a patient day. So it kind of equates the two and helps us see overall how that outpatient activity is affecting everything that we do. So it's kind of an equator, if you will.
Yeah.
It equates outpatient to inpatient.
It compares it to an inpatient instead of just looking at the ambulatory side of it. Okay. Do you ever look at the ambulatory side to see if it's...
Sure. We definitely look at both.
Okay.
But I was trying to bring you a metric this month that gives us a better overall picture of kind of how the system is operating from a volume standpoint. It's very hard when you look up and down the line and you see green and yellow and red. It's just kind of very, there's a lot of variation. So this one would help us kind of look overall and see where we are.
It would help you look at admissions. Outpatient may go up in volume, but we are comparing it to an admission to the hospital, which would show it as admission. And one of my concerns or question is that just because your volume go up in the outpatient doesn't mean that you'll get more patients, does it?
No.
You can see it in the ER, but that's just one of my concerns.
No, and your point's well made. It's just more intended to help us see a resource utilization from the entire system.
Okay.
In terms of that outpatient activity.
Okay.
Yeah. All right, if no questions on the stats, we'll hit the financial metrics real quick. Payer mix continues to be much stronger in the commercial area, the purple category, and then we've also seen the green category, which is Medicaid, continue to fall into the orange category, which is self-pay, with the state's requirement starting in April to unwind Medicaid and start to require members to re-enroll in Medicaid. We've seen that decline, continual decline there, and that's the major highlights for the payer mix. Cash has been strong. Of the last 12 months, 10 of the 12 months we've met cash goal. In those months we did not meet. We have seen a nice rebound usually the next month. So we are right in line with our cash to net revenue calculation for the year. And then we do continue to see a connections enrollment climb there up to roughly, we're right at close to 45,000 members now in connection. So we'll dive into the dashboard that I mentioned. I won't go through each one of these. I will tell you that there are 12 metrics on the dashboard, and of the 12, 8 of those we are meeting at least a minimum threshold or greater. And I'll highlight a couple of things I think are important. The board, in particular, has asked us to really be more visible with what are we doing from an efficiency standpoint, either cost savings or revenue generation. And we've got our Fit for Growth number there right below the bottom blue bar. We have a 2-year target in Fit for Growth of 34 million. You see that 33.9 rounds up. And we are projecting on that 34 million to be right at 109%. Right, as we look at the ending of the fiscal year, that's where we expect to be. I would clarify that not all of that has come in. It is not all recognized savings. We have to look at the initiatives that we are undertaking and kind of predict where we think we're going to be. But we would come in around 37 million. So the point I would take from that is we had a roughly $95.5 million target for that Fit for Growth opportunity, and we are on track with that. And I'm encouraged by that because some of the initiatives identified by PwC in their work, we're really slower to adopt. And so we're capitalizing on other things as well in that operational efficiency. And then a couple of things on foundation. We are very close to our philanthropic giving number. Shannon and her team really making some improvements in the foundation. Board giving, you can see that is measured in months. So of the number of board members times the number of months served, how many were contributors. And then our employee giving, a little bit about that. We have grown from 3% at the beginning of the year to already 9%. So we are measuring around 9%. And so we set a little bit higher threshold at 10%. And then that puts us really right where our public peers are. Parkland is running 9%. We have some numbers on Grady at 7%. So we've actually done some research on where do we stack up with respect to some of those other facilities and continue to improve those employee giving numbers. So anything else you would like to ask on the dashboard?
I think more for me, Medicare retention.
Yes, sir.
Can you clarify that just to make sure we're all on the same page on that?
Sure. Over the last several years, we've retained a lower percentage of Medicare than we would like to see. So there's a couple ways that occurs. One is a connections patient that ages in. Two is a Medicare patient that chooses to opt for another plan that we don't participate with. So this goal or category is really intended to, how do we keep those patients? So there are a number of efforts starting now or have been started to look back about 12 months from 65 years old, starting around 64 years of age, and really build a campaign around marketing to them I was thinking about this morning. There's this Obamacare joke years ago, or I can't remember, it was keep your doctor. Well, there's a lot of controversy about you didn't get to keep your doctor. Well, we can say keep your doctor, and that's a lot of the marketing strategy around we can retain you at JPS. You just need to stay with a plan that we participate with, and then try to capture them before they make a decision that puts them in another system. So does that answer the question?
Yes. Do we set the goal for connection? What percentage is likely to meet and to go into our Medicare program?
Like we didn't set a goal specific to connections aging into Medicare, but we do have that number. We can actually present that to see how many are actually staying with JPS. It's a good question.
I'm with DT on that one. I think that would be more meaningful. You already have a relationship. How many of those stayed with us, or at least we would be, to see if we're capturing that audience, yeah. I know the overall growth, because I help folks sometime with their what plan should I have? And I said, where are you going? And they tell me, I said, well, check with them and make sure that they are in this plan. And that's part of the education, and that helps folks, so.
Yeah, we can possibly tweak this a little bit to where we report both. I don't think that's a major deal. I think there is a strategy around both sets of population, especially if we have patients that are participating with, say, Cigna Medicare, but they move to Humana, which we don't have a stronger relationship with. We definitely want to keep an eye on that as well. So
That does help us measure the churn. Like, you happy because we give it to you, but when you have a means to pay for it, you took off somewhere else.
right, yeah. Okay.
When I looked at the dashboard, I looked at the JPS connection, and the stretch, the stretch is the 52,000.
Yes, sir.
Actually, that's not a stretch. If the community would respond, we could really achieve that. So what I've done is ask in our ministers' union to meet and to declare a health care day where we can then talk to members in the membership after service on JPS connection or healthcare period. Because one of the problems is when I go to the meetings, you hear so many of them pastors themselves who are not anywhere. And then you want to have a big offering, raise money to help their healthcare needs. So I'm going to let you know when we're going to do that to see if we can address JPS connections.
Okay. All right, if no other questions, we'll move to the income statement for the month of March. As you can see, a lot of the positivity is around net patient revenue. With that favorable payer mix, about $5.2 million in that patient service revenue. I would highlight the other operating revenue. Zelia, in particular, has done some really good things around MHMR, as well as we have a program called Tchd that is really the contributor for the other operating revenue excess there. So really commend her for doing things that are thinking outside the box, and really a lot of that is just attributed to that behavioral health service line. So expenses are, as I said, slightly favorable to budget. I will start to bring more information around salaries and wages. We do see what would appear to be in the month of March a really high number in salaries and wages. We are experiencing the first round in March of our employee market increases, and what we do in that process is we do a market study across 3 large databases by job code. And that market study comes back and tells us where we need to make improvements in compensation. And so that was implemented in March and will also continue in April for leader compensation. We are running a little bit ahead of our budgeted FTEs. And then we also are running on the acclaim side a little bit higher in salaries due to what I would call just the influx of members that we've had in Cigna. We are compensating for that with kind of working additional shifts in our physician group. So we do have a significant amount of salary overage in acclaim as well. It's about $2.6 million, and the hospital is the rest of that. What I would...
When you do market adjustment, is that retro or is that going forward?
Yeah, in this particular case, it was only retro to the beginning of the pay period, so not back to the beginning of the fiscal year.
Just that beginning of that month?
Yeah, well, if we did that in pay period 21, then we took it back to the beginning of pay period 21, so.
Have we forecast what it looked like at the end of the end of a fiscal year, like August 31st, and then come September, what's the delta gap on that?
Yeah, we are working on that right now. We have a projection through the end of '24, and we're very close to right on target. That's the second point I was going to make, is you really have to look at contract labor and salaries together. It's that line item for salaries and related expenses. You got to look at salaries and contract labor together. And if you look at where we're at now, that 12.8 million year to date in contract labor under, that's going to project out to close to 24 million for the year. So you got to look at everything together, because a lot of those positions that we've hired are helping us offset in that contract.
That should move a certain percentage for retention too, right?
Yes. A little bit on purchase services. We are really seeing some of those just contract service items in IT, as well as some designated funding that has not been utilized yet, specific funds that we budgeted for. And then we really have about $500,000 in outside medical services that are we're seeing less utilization in outside medical, which is a positive indicator for that connections population. And then, as you can see, the consolidated net income is improved by that investment income of about 800,000, roughly, almost 900, and then 9.8 million favorable in net income. On the balance sheet, we really had a nice decrease in AR for the month of about 2 million. We had seen a steady run up in AR over the last several months, just with revenue and patient activity, and so we finally started to see a little bit of a drop in AR, to 83 million there. AR days continue to remain stable. We were at a little over 42 days in the month of March in AR days. So cash is sitting at 432 days cash on hand, and of that, 190 is restricted, of course, for that board restricted master facility plan. So that's 180 days of that 432. Anything that completes my report on the financials, and nothing else would request approval on those for the month.
Move approval.
Approval. Second. All in favor, signify aye.
Aye.
All opposed. Motion passed. Thank you very much, Roy.
All right, I think I'm your first contract too, so I'll just.
Let me ask you a quick question.
Sure.
With all the construction, all that stuff, what do you think 2025 would look like from the asset standpoint?
From
From the total asset standpoint, is that going to move up to close to 4 or 3.5 billion? Because I know it's climbing up quite a bit for the last few years.
I can certainly do a projection there on, for next month, if that's something you would like to see from an asset standpoint.
If it's material, bring it back. If it's not, don't worry about it.
Okay. Yeah, I'll make a note.
All right, sir. Your item B.
So item B is an agreement that we are requesting approval on. We, at JPS, we have a number of patients we need PET scans on. We cannot provide PET scans currently, so we do contract that service primarily for staging of cancer. And so this is an arrangement with Tchd, and we are requesting approval of about $360,000 annually, as well as $1.8 million over the 5-year period. One of those services that we just can't currently offer on our campus, so we do contract that.
Are they doing the billing for us, or are we doing billing and then we just pay them?
I couldn't make that out, DT.
Are they doing the billing for us, or they doing the billing for themselves, or?
So these would be on self-pay patients that are connections, and so we pay them for those. But then if it's an outside patient that has insurance, then they would do their own billing.
Okay.
Yeah, correct.
Any question? If not, a motion.
Second.
Second. All in favor, signify aye. All opposed, motion pass. That's with the exemption, though, right? 2 bid, right?
Yes, that is correct.
I just want to make sure. All right, item C, please.
Okay, item C is a agreement. Historically at JPS in the accounts receivable, we have such a high volume of outpatient activity, clinic visits that typically we bill for that are in that lower dollar range. So historically, we've had a difficulty. We work these higher accounts that are higher dollar, and we spend a lot of effort on those, and we don't have as much time to work on the smaller accounts. And every dollar counts when you look at the accounts receivable. And this agreement helps us to do that with some outside help. There were 6 respondents to this RFP, and it's roughly $340,000 annually, and also about $1 million over the 3 years remaining on this contract. So would request your approval on that.
Is this day one receivable also as well?
I'm sorry?
Is this day one receivable also?
It's not. It's 90 days.
90 days.
So we are working those for 90 days internally. Correct.
It says performance based. So what do we anticipate for paying?
Oh,
What would we get?
we would net out close to 96% of our collections. So we do pay a small fee. Did I answer your question?
No, so we pay this company when we get paid, right?
Correct.
So presumably we're not paying the company more than
Oh, no.
the payment. So how much are we getting?
So it is a fee based on what they collect. So we would never trigger a payment to them, and it's 3.5%.
Okay, so this is a significant revenue.
Oh, from a net standpoint?
Yeah.
Yeah, we were not performing as well internally on these accounts from a collection standpoint because we spent most of our time working the higher dollar accounts and didn't have enough staff to cover the lower dollar.
So if they identify that they have insurance at that time, they return to us or they collect and?
Most of these are already insured because we don't send them uninsured. So these are insured already, and there would not be a return to us if they found insurance. Good question.
Any more question? Otherwise, entertain motion for approval.
Move approval.
Second. And all in favor?
Aye.
Aye. All opposed, and motion pass. Next one is Jill, I think.
I think it's me. It gets kind of.
Okay.
It gets kind of confusing. This item is really more clinical, and that's why it gets confusing, but it is a supply chain item. So currently, I'm your supply chain representative, among many other things that I represent.
Multitasking.
But
Combat pay here? You get combat pay here.
No, just hostile duty pay.
It says other duties.
Other duties.
Fine.
I really took a hard look at this particular agreement because as a CFO, I look at that number and I go, wow, that's a significant spend. But we did a study 2 years ago on hospital-acquired pressure injury. And what we did was we looked at the cost of this technology in the way we turn patients, particularly in the ICU. And what happened over the 2-year period was a reduction in our pressure injury rate from about 3.4 to 1.45. So we made a 42% improvement in pressure injury. And really, when you take the cost of this contract and you look at the savings from not having to treat the pressure injuries, there's a return of about a little over $1 million by doing that. So yes, it is a expensive technology, and the spend has also increased over those 2 years because we've become more effective at using it and preventing pressure injury. So questions on that, it is $1.6 million annually, and then 5 years, 8.2.
We assume this will help us with lower down our average length of stay.
Lower length of stay,
Yes.
for sure.
Antibiotic cost, all kinds of downstream. Yes.
Good things. Approval
So moved. Yeah.
from the two physicians. All in favor? Any opposed?
Thank you guys for your time today.
Thank you, Rory. Did you?
And you're not coming back anytime soon?
I hope I'm done for today. Maybe next month.
Yes, ma'am.
Hi there. I actually have E, F, and G kind of together. We had 3 awardees as part of a spinal implant RFP, and requesting your approval for these 3 pricing agreements. All are included in the FY24 operational budget. I'll start with the first one. It's Globus Medical. It's $932,000 annually. Total 5-year contract cost of $4.46 million.
You want to go all three?
I can. Absolutely. The second one is Johnson & Johnson, $278,000 spend, 5-year term again, $1.39 million. And the last one is Halmedica Osteonics, part of Stryker, $556,000 annual spend, 5-year cost of $2.78 million. Again, this is for spinal implants, devices, equipment, and other components for those surgeries.
Question on E, F, and G from our group? If not, we're going to take the motion for all 3 of them at the same time. So as well.
Okay, move approval.
Second.
All in favor, signify aye.
Aye.
Any opposed? All 3, E, F, and G passed. Thank you. Item H. Hi, Joy. Morning.
All right, I'm bringing forward H, I, and J, but all separately. So we'll start with H. But yes, good morning. I'm bringing forward for your consideration for approval a contract with Ruedas Property Investment to sell a vacant property that is located at 1422 East Magnolia Avenue. This is a very small residential lot, zoned for residential. It is on the east side of 35, so over on the other side, actually a lot that we've had since about 1988. Listed this as we assessed what value that might have for the organization. It didn't have any adjacencies to other JPS properties, and really from the location of it, we felt it was the best to sell and receive the revenue back to the organization.
Does this one need to go back to the Commissioner Court?
Does it have to go back to Commissioner's Court?
It will.
Okay.
Okay. Just want to make sure.
All right. Yes, thank you, Daphne. Okay.
Any question?
Move approval.
Second, but all in favor, signify aye.
Aye.
All right.
Any opposed? None. Motion passed. Next one, please.
Okay, next one for I is I'm seeking your approval for a construction agreement between Hutcherson Construction and the district. I was here last month talking about our chemistry analyzers that we are replacing. This is the construction company that was selected through RFP process to help to do that construction so that we can bring up these new chemistry analyzers.
Have any question? This is part of the Vision GPO also as well, right? Mhm. Motion for approval?
Second.
Second. All in favor?
Aye.
Motion passed. Item J, please.
All right, and so this contract, I'm seeking your approval of a reagent rental agreement between Biorad Laboratories and the district. This agreement allows us to process our hemoglobin A1C, and actually was an opportunity for us to save a little bit of money in that cost. We pay that on a cost per patient reportable, so it provides the equipment, and then we are able to use a reagent for testing.
Any discussion? If not, motion for approval.
So moved.
Second.
All in favor, signify aye.
Aye.
Any opposed? Motion pass. And thank you, Joy.
Thank you.
Mr. CIO. For the record, he was here half an hour early.
I believe in business continuity. Good morning, everybody. I'm here with a request for Cheers call management and Cheers campaigns. This is a request of about $420,000 for implementation and almost $800,000 over the course of the next 3 years. This is part of the Access as well as the Unified Communication Project. What this is a set of tools. It is Epic's Customer Relationship Manager tool set. It's also a set of tool sets around call center integration, and it's a set of tool sets around campaign communications. The focus of this is really to streamline overall call centers. This is a patient experience tool, so think of yourself in the traditional call center screen pop, you get limited information. This puts it directly into Epic, so when the individual calls in, there's a screen pop, which means you have all the information associated, but you also have everything in front of you from an Epic perspective to be able to do other services like schedule, et cetera. So it really eliminates the swivel chair, it integrates. It's also a data focus on a data accuracy because it's all within the same tool set, so there's a lot of checks and balances associated. But most importantly, it also sets the foundation for the future. Obviously, campaigns, whether it's text, email, et cetera, will be out and live towards the end of November. But this also sets the stage for chatbots and RPA, remote robotic process automation, and AI in the next 18 months. Any questions?
Can I assume that this is a better, since it's self-contained,
Yes.
it's better for us for HIPAA and all that stuff also as well? Okay. Yes, sir.
No, I don't have a question on this. I have a IT question, but I think I need to wait until after the board meeting. I don't want to ask that in public view.
Okay, yes, sir. We can go do. Any motion for approval? Second by Reverend Ralph.
Thank you very much.
All in favor, signify aye.
Aye.
Any opposed? This one also carry exemption for bid also as well. Thank you. Do we have anything closed? We do not have anything in close, so
Okay,
the meeting is adjourned. Thank you.
right.
Are we offline now?
Yeah. Well, no, you're not offline yet. You're not offline.